Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. So today what I'd like to do is I'd like to respond to a little bit of Twitter drama. This is actually something I don't think I've ever done, and I am actually doing it with a well-defined purpose in mind, and I think that it is an incredibly important concept that I have actually talked about multiple times on this channel. In fact, I believe a majority of my recent videos or videos within the last year or so have been focused on this particular topic, and that is talking about the concept of an OMI, or an occlusion myocardial infarction. And I believe that the particular conversations on Twitter are very relevant to this, and in some ways, in some key areas, really mirror the way in which I conceptualize this and in which the way I feel. So this is actually really in regard to some posts by Dr. Stephen W. Smith, or Dr. Smith, or Stephen Smith. Anyone who is at least even peripherally involved in ECG interpretation should be familiar with that name, because he, along with others like Dr. Myers and et al., there are a list of about a half a dozen or so people I can think of that have been highly influential in the slow change that is occurring when it comes to how we conceptualize myocardial infarction. And Dr. Smith is among those half a dozen, maybe even fewer people that I can think of that have been absolutely instrumental in changing things. And he was one of the authors of the OMI Manifesto that was published back in 2017. And so this is a conversation that happened within the last day. This is only about a day old, so it's fairly frequent. And essentially, it was a conversation in regards to an ECG that another physician posted, talking about somebody having chest pain, and Dr. Smith identified this as an OMI involving the left anterior descending artery, the LAD. So this would be a lateral, or the LAD, this would be a anteroseptal infarct. And in this, in the subsequent conversation, Dr. Smith, and I'm going to quote, "Get rid of STEMI. It is destructive and frankly stupid. Makes no sense whatsoever. Why would you name a disease after an imperfect part, STE, ST elevation, of an imperfect test, ECG, for that disease? It is like calling appendicitis a quote-unquote high white count abdominal pain." That is an interesting parallel, actually. Name it for what it is: an occlusion myocardial infarction, unquote. All right. So, bold statement, and I roughly believe the same thing, but as you might imagine, there has been some pushback on this. And there have been some people that have, saying, "Hey, look, you're obsessed with this. You're obsessive." I think calling things STEMI, obviously STEMI it's easy for us to identify. It's easy to conceptualize for most people. It's in our vernacular. It's in the way in which we communicate. Everybody's more or less on the same page of what STEMI is. Why should we get rid of it? It's so well known. And some of the follow-up posts by Dr. Smith are kind of interesting, and I just kind of want to go over them. So what is he saying here? He's a couple people, and again, I don't want to get into specifics and get into the drama, because this is actually really good to see people with some different takes on it, and the back and forth communication. I'm not saying this is bad. This is actually good communication, and I think it is a very good discussion worth having. So in response to some of the pushback from that prior statement, he says the following, quote, The insistence on STEMI kills perhaps 20,000 Americans a year. Where does that come from? That actually comes from some of the studies that I've referenced in my prior videos as well. But he goes on to say 200,000 in STEMI OMI with delayed intervention. So approximately 200,000 patients per year are diagnosed with an in STEMI, all right, using this older terminology, or this classic terminology, if you will. 1 year mortality, 20% versus 10% for STEMI, because the in STEMI OMI have delayed PCI. So what he's referencing again is that in many studies, in some studies, people that have in STEMIs tend to have higher mortality than STEMI, using classic STEMI in STEMI criteria to identify those categories. So if you have an in STEMI, your mortality rate is higher than if you have a STEMI, and that all the evidence seems to suggest that's really just due to the delay in care, right? Where people go, oh, in STEMI, that's, I can medically manage, they don't need to go to the cath lab, and those patients tend to fall through the cracks. They tend not to have an intervention, or an intervention that occurs in a timely manner. Generally 6 hours or less is what a lot of people would argue, but the guidelines vary from organization to organization on that. So that's kind of what we see. So he goes on to say, this is why I am obsessed with it. Are you fine with that? One could say, and we're going to continue on down here. One could say that continuing to promote a failed classification of MI just because it is conventional is evidence of ossification of the mind. You should get obsessed with OMI too. So he's saying, yes, I am obsessed. I'm obsessed because perhaps up to 20,000 people a year are dying because they are not getting the appropriate care, because we are throwing them into this STEMI, go to the cath lab, in STEMI, don't go to the cath lab. And then there is some pushback, people saying, well, you know, ongoing chest pain is an indication for going to the cath lab, right? So, and then the follow-up argument is, yes, but not most, but a lot of people, their primary decision-making isn't as nuanced, and it really does come down to, in a lot of cases, STEMI cath lab, in STEMI, no cath lab. And then that's the primary decision point, and then they sit in the ER and we do whatever, and there's a tendency for them to fall through the cracks. Whereas if we had a paradigm shift, perhaps those people would be far less likely to fall through the cracks, because we're using a OMI paradigm as opposed to a STEMI paradigm. And the number of STEMI equivalents continues to increase, right? I've talked about what a STEMI equivalent is in prior videos. And what are we up to, 9, 10, something like that, right? Beyond the initial 5 or 6, even I think it's 5 or 6 that were identified in the 2022 ACC guidelines. We've got others as well, as Longer's pattern and things of that nature. And so, you know, again, people are like, well, why are we doing all these mimics when it's very clear that OMI better encompasses all of this stuff? And then again, there's been some pushback on those statistics, those 20,000, where, you know, people are saying, well, it's not necessarily accurate. And, you know, looking at the majority of the studies, PCI happened with more than 24 hours. When delayed PCI, less than 24 hours, no mortality. The mortality difference closes. And there have been some studies that have been referenced there. And then Dr. Smith replies to that, well, less than 24 hours, almost all are done at greater than 6 hours. So he's saying is right about 6 or more, after about 6 or more hours, whatever damage is done, whatever myocardium you're going to lose, right? at which time occlusions have already lost almost all myocardium. Furthermore, by the time they get PCI, the artery is often open spontaneously, but it is too late. People don't realize that, right? That an occlusion of a coronary artery is often a dynamic process, right? And that's one of the things, I've talked about this years ago, actually, in some of my earliest videos where I just started to become aware of, I don't think I was using the moniker of OMI, but I was becoming aware of the problems with the STEMI in STEMI paradigms. I think as far back as late 2017 or early 2018, after I heard a lecture about some of these issues during a emergency nursing conference. It was in Ohio. I think it was late 2017, so it was right after the OMI manifesto was published, I believe. So very early on, even I was starting to recognize, there's something to this, there's something going on, although I hadn't really solidified and gotten fully on board with into the OMI camp like I am today. So let's see here. So furthermore, by the time they get to PCI, the arteries often open spontaneously. Like I said, heart attacks, myocardial infarctions are often very dynamic, and dynamic changes on your ECG should be very concerning, right? But it is too late. Every randomized trial of InSTEMI, which included patients with active chest pain and did PCI at less than 2 hours, showed benefit of early intervention. That is why this is very important to differentiate the United States from Europe. This is why Euro InSTEMI guidelines mandate less than 2 hour PCI for such patients. All right. And so essentially what he's saying is that we are misinterpreting the literature, and I actually tend to agree with that. So that's kind of, there's some additional back and forth there, but that's kind of the crux of that particular conversation. And so again, I think this is an important discussion to have. And the reason that I bring this up is that I have had similar discussions. The work that I've been doing over the past year with the college, I've been really pushing the OMI paradigm, and this is one of the areas where I feel a fair amount of frustration because I am not in a position to change the medical zeitgeist in my community. That really it really needs to come from physicians and other providers who are making higher level decisions. And this is the frustration that maybe some of the frustration I feel in alignment with Dr. Smith is I'm seeing this. I can't go into any specifics, but I have, because part of what I do is clinical. I spend, every hour that I have a paramedic student in the hospital, I have to be in with them. I am QIing their charts and interfacing with them while they're riding on the ambulances. And this is actually a pretty common finding where my students, or sometimes the preceptors of students with, look at an ECG and are concerned, and then they are completely disregarded by the receiving facility. And in a lot of cases, the response they're getting is, well, this is not STEMI, right? And again, I can only do so much, right? I can teach this, I can push this, I can talk to my students. I've even, luckily, I have a pretty good medical director who listens to me. And even though he hasn't quite pulled the trigger on OMI, at least we now have a list of so-called STEMI equivalents, right? And so our students are able to activate what we call a code heart, right? Or cath lab activation, or at least send that request through to the receiving facility based on criteria that goes beyond STEMI. Okay, so at least we have that. The problem is, I can teach that and I can have my new students thinking differently about myocardial infarctions, but the physicians at the receiving facilities are not on board. And I had a discussion in the last few months with a physician in this local area. I'm not going to name drop or anything like that, but this is somebody who is involved with EMS in this area as well. So kind of high level, and essentially what was communicated to me was that it didn't seem like all of this work I was doing really will amount or could amount to anything, because, well, nobody's really on the same page as you, and so it doesn't make any sense for you to teach all this stuff to your students, because it's not like any of the providers in this area are on board with it anyway. And so it just kind of, why do it? It's not worth it. And clearly you're not, right? You're not going to change anyone's mind as physician-wise. And so it's absolutely frustrating that's what I'm running into. And unfortunately, like politics, sometimes when it comes to healthcare, for things to really change, people kind of have to die out or retire. So you have to have generations of older providers who are very ensconced in certain paradigms that are, for a variety of reasons, going to be very reluctant to change. They are ossified, as Dr. Smith, to quote Dr. Smith, they're ossified in their thinking and their cognitive paradigms. And they kind of have to retire and go away, and then newer people move in, and then the paradigm shifts. Unfortunately, what does that mean? Tens of thousands of people a year dying or having substantial mortality for years before that happens. And what I'm saying is, I wish it wasn't the case, and I feel like I have a very limited ability to impact higher level changes. I actually have communicated we actually have a medical school in our community, and I've been in communication with this medical school to see if they would actually let me go there and present my OMI lecture and talk about the history and the evidence and the data. And it's essentially the same lecture that I have recorded here on YouTube, a little over an hour long. It would be a variation of that particular lecture, and it may or may not occur. I've had some positive feedback, and so I'm still in discussion. So we'll see if it happens. But that said, what it really comes down to is the medical community, because I'm not a physician, right? I'm not a doctor. And so it doesn't matter how well informed I am, how articulate I am. It doesn't matter, because I am not a part of that club, so to speak. And I'm always going to be an outsider coming in. And it just kind of is what it is. I hate to use a tautology there, but unfortunately, I don't think people like me can really impact a lot of high-level change, because I'm not in that club, so to speak. And so this is why it is so important that physicians grapple with these ideas, and physicians and high-level providers, particularly providers that are in emergency medicine, critical care, cardiology, that are going to be making these decisions, engage with this material, because ultimately they are going to be the ones that are going to push for these larger changes. So that is kind of my stance on this, that I feel Dr. Smith's frustration, although I'm probably seeing it from an outsider perspective, right? That I'm kind of an outsider trying to enact changes in systems and running up against a lot of pushback. Whereas he is running into this pushback as an insider. But I really do, at this point, I really do believe that the major changes need to come from inside, because I don't think people like me are going to have the ability to impact the zeitgeist, if you will, of acute coronary syndrome substantially. So that is my rather negative or pessimistic view on things. But I just wanted to put this video out and put it out there, and see what you all think. All right, thank you all so much. Take care, and we'll see you in the next video.